Oh, hey, bet you didn't see me there. We're gonna start with the heart. Going over our structures, we're gonna start on the right side. Sitting on top of both atria, we're gonna have these structures called the auricle, this little puffy thing. What that is it's actually an extension off of both atria. So what that does for us is when we are working at max capacity, when we have extra blood flowing through the heart, that maybe would overflow or outside the limits of the atrium, that will flow into the auricle. Okay? But as humans, very rarely are we working at max capacity, so we really don't use these as often as, say, other mammals would. But as we open this up, we'll be inside the right atrium here. We'll see this textured structure. This is going to be our pectinate muscle. This will contract to force blood from the atrium into the ventricle during the cardiac cycle as we go through systole and then diastole and things like that. As this muscle terminates, we have this structure called the crista terminalis, right? Where it then will smooth out on that atrial wall. And then this pectinate muscle will actually be more so on the anterior superior portion of the atrium. As we look at the internal structures in here, a couple of these numbers you can actually ignore, but number 55 is going to be called our fossa ovalis. So after birth, this will actually close and it will just be a structure. However, in utero, this is open. And this allows for blood to pass between the right and left atria because our lungs are not formed until 28 to about 32 weeks, fully formed. And so what this does is this allows for blood to bypass the lungs to be oxygenated, so blood is just being shunted between either side of the heart here. But then upon birth and then breathing, that will close, should close. Some people will have what's called I guess I should say in utero it's called foramen ovale, and then after it closes it's called fossa ovalis. Some people will have what's called a patent fossa ovalis, and that means it's still partially open. And a lot of times these people can make it to adulthood and they are perfectly fine. They don't even know that they have it. But sometimes if they start doing extreme exercise, the issues can be exacerbated and then they realize they're having some issues with blood flow. Also on the inside, we're going to see this number 33. This is where the inferior vena cava, you see right here, is coming up, bringing blood, deoxygenated blood from the lower portion of the body up to the right atrium to be oxygenated, and it'll dump in here. 58 is going to be where the coronary sinus dumps into the right atrium. That is going to bring the deoxygenated blood from the coronary blood supply back into the right atrium. As we leave the right atrium, we're going to go through the tricuspid valve. Okay? Tricuspid has 3 cusps. Okay? So we can see 1, 2, 3. Those will be attached down onto papillary muscles within the ventricle wall. All right? So we'll have the leaflets here. We'll have these little strings called our chordae tendineae. These help anchor the valve itself into the muscular wall of the ventricle. And then we'll have our little papillary muscles. Then this textured area on the ventricular wall is called trabeculae carneae, which is Latin for meat columns. Fun fact. Then as we go through and we have ventricular contraction, blood is shunted up through, we'll hit this smooth area called our conus arteriosus, okay? And then we go through our pulmonary semilunar valve. Okay? We go then into the pulmonary trunk. These are going to, the word trunk, along with the word common, is indicative or meaning that things are going to split. We then go into our pulmonary arteries. So remember, arteries are away from the heart. Veins are coming to the heart. So normally in models or pictures or whatever, arteries are depicted as red, veins are depicted as blue. Okay? But on this, they're flip-flopped. Okay? So these pulmonary trunk into arteries are going to be blue. They're taking blood away from the heart to the lungs to become oxygenated. Then as as we wrap back around, we will drop into the left atrium. We do have pectinate muscle in the left atrium, however, it's usually, this is a model, keep in mind obviously, but we do not have a whole lot of pectinate muscle because usually atrial contraction it doesn't really happen, and there's more so passive ventricular filling just due to the force that's building up. We drop into the left ventricle where we see the exact same structures with the exception of the valve. This is a bicuspid, so we have 2 instead of 3. So one way to remember that is you try before you buy. Okay? On the left side, it can also be called the mitral valve. And then both of these can also be called the atrioventricular valve. You would just have to put the side in front of it. So this would be the left atrioventricular valve. So same thing, the chordae tendineae anchor down into the papillary muscles, which anchor into the trabeculae carneae. We will then leave through up into the aortic semilunar valve, okay, where we then come up into the ascending aorta, the arch of the aorta, and drop down into the descending orthoracic aorta. This first branch coming off is going to be our brachiocephalic trunk, which will give us our right common carotid, which will go up into the neck, along with our right subclavian, which will go to supply the shoulder. Subclavian, clavian with clavicle, sub meaning below. 14 will be our left common carotid. We'll go up into the neck. Common meaning it's going to split. We'll get right and left carotid arteries, or excuse me, we'll get internal and external. And then 15, we'll have our left subclavian artery. Also, what we can see here is this little structure right here. This is called our ligum arteriosum. And so this is another fetal remnant during or in utero. This is open also to allow for the passage of blood between the pulmonary trunk, or what this shows more so is the pulmonary arteries, and the aorta. And then upon birth and first breath, this should shut based on the pressure differential. And so more so than the foramen ovale, or fossa ovalis, this will close automatically. We don't really see these being patent. And so this then will turn into a ligament because nothing's going through it, so it'll harden, things like that. Where this becomes problematic is extreme stress or trauma to that area. For example, like a car accident will actually can pull these structures apart, and then you have what's called an aortic dissection. And then as we have that, there's obviously a large flow of blood coming through here, and that can go through that hole and then cause people to bleed out and die. Okay. We'll also talk about some other structures that apparently I can't get that off. Coming off of here, coming off of the base of the aorta, we'll see our right and left coronary arteries. So this 31 would be my right coronary artery coming down, wrapping around. Okay. This 29, this will be my left coronary artery coming down, wrapping around. Now, left coronary artery is going to branch. It's going to branch into my left anterior interventricular branch. It can also be called your left anterior interventricular descending artery. It can also be called your left descending artery. There's a couple different names. Commonly, it's just referred to as LAD. Okay, if you put that on the test, it's not right because I want to know the whole term. But this is also nicknamed the widowmaker. There's a large percentage, I think it's something like 80 or 85% of people who have a blockage here die because it supplies the septum. This would be our interventricular septum, as well as the left side of the heart. This blood coming out of the left side of the heart is going to the systemic circulation to supply the body. So you can imagine if blood supply to this side is impeded, that is problematic. Also lying in what's called this anterior ventricular sulcus, which is just a fancy word for a ditch or a groove. We also see the great cardiac vein. So if we have a very large artery supplying blood to an area, we need a very large vein to take that blood away. Also, this left coronary artery is going to branch off into what's called our left circumflex branch. And that left circumflex branch is going to wrap around and to supply other areas of the body. Let me see if I can get this out. Nope. Also on the back side, there we go. As we wrap around, this right coronary artery is going to give off our posterior interventricular artery here, and that is going to run with the middle cardiac vein, and that will empty the blood that's supplied by the posterior interventricular artery. And then we'll have this larger vein that's going to expand, this number 27. This is called our coronary sinus. It will lie in what's called the coronary sulcus. And so what that does is this is where all the blood, the deoxygenated blood that is brought back from the actual coronary circulation, and it will be dumped back into the right atrium so that it can go through the circulation and get oxygenated. One thing that you'll notice is when you're looking at the naming for the vasculature on the heart, if we're talking about arterial supply, we use the word coronary, so right and left coronary arteries, things like that. If we're talking about the veins, we use the word cardiac. So make sure you notice the discrepancies there.